We're going to be talking about the radial forearm flap today. This is a pretty utilitarian flap that's kind of a workhorse in almost every microsurgeon's armamentarium. It provides thin fasciocutaneous tissue that can be used to resurface almost any part of the body as a free flap, but as a rotational flap has utility around the forearm and elbow, and in a reverse fashion can also be used to cover the volar and dorsal hand. You're going to start with the evaluation of these patients by obviously confirming that they have a complete arch with a standard preoperative Allen's test, but as we know that's not always going to be predictive of what you find from an anatomic standpoint. So I have a couple of ways when I dissect this flap that I check the flow before committing to harvesting the radial artery. At the beginning of the case, you'll identify the radial artery and design the flap centered over the top of it, and you can include nerves with it as well. You may oftentimes include the cephalic vein as a drainage also. So typically how I start this flap elevation, we've designed it here as a distally based flap that can be used as a free or rotational flap. I'll start by making my distal incision. That you can see here, incised through skin, subcutaneous tissue, and through the antebrachial fascia. Identifying the FCR as well as the brachioradialis, where the radial artery exists between the interval between these two. The radial artery along with its vena comitantes, which you can see here. And it is relatively superficial, so we'll identify that radial artery there. Usually I'll place a clamp on it. I'd usually raise this flap under tourniquet control, release the tourniquet, place a clamp on the radial artery. Once I have a clamp on the radial artery, I'll release the tourniquet and make sure that the hand has perfusion to it. Once I can confirm that that's the case, I'll go ahead and distally ligate the radial artery. Subsequently, we'll commit to the rest of our skin paddle with care taken along the radial aspect of this to identify the cephalic vein in case you plan on using it for drainage of the flap itself. I tend to be relatively conservative and take a relatively broad swath of subcutaneous tissue along with this and discard it later as needed. So you can see here, you have to be very careful about the dorsal sensory branch of the radial nerve in this neck of the woods. Many times, unfortunately, in our injected specimens, the arteries have great injection, but the veins are a little bit more of a challenge to see than they are in situ. We'll do our best today. And so, we'll elevate and see if we can find the cephalic. And this is the cephalic vein right here. And generally associated with it is going to be our nerves. So we'll just be careful as we dissect and make sure that our nerves are preserved and not injured. A neuroma associated with these can be quite problematic, and here you can see the nerve. And in this level subcutaneously, it may also be lateral antebrachial cutaneous nerves, which can be harvested along with the flap to provide sensation, but we don't generally do that. So I'm separating gently the nerve away from the flap. In this case, for the sake of avoiding a larger dissection, I'm going to take this along with just its artery and its vena comitante. So I usually will commit to making my more proximal incision along the actual radial artery itself, usually a curvilinear one for sake of improving my exposure. And again, I'm back up on tourniquet at this point once I've divided the radial artery and confirmed my hand perfusion. It just aids in the speed of dissection. And again, I'll commit to my entire skin paddle here. And then we'll elevate distal to proximal, making sure that we maintain our radial artery up with the flap itself. And here you can see our radial bundle. Just elevating the fascia up off of the distal forearm musculature to ensure that my artery is maintained within the flap itself. And here you can see the radial artery nicely exposed. Thank you. We maintain the connections between the radial artery and the overlying skin and subcutaneous tissue so that we have perfusion to the paddle itself. And here I'm freeing it on its underneath surface. Good. I'm just going to flip it back over and then elevate it. Now that I have the artery captured with my flap, I'm going to elevate everything deep to the artery itself, maintaining its connection and being very careful to maintain the peritoneum over the flexor carpi radialis here. So while you want to get deep, you want to make sure that you don't disrupt the peritoneum so that it will take a skin graft for you in a secondary fashion. And so now I'm trying to just elevate this away. And so now I've got my artery up and elevated. I'm going to continue to elevate my skin, subcutaneous tissue here. Trying to stay deep to the artery with all the tissue that I take up with my flap. And again, you can see our artery up with our flap and gently elevating everything else away from it. Little perforating vessels that will be ligated with bipolar or with clip as we elevate. And then now I'll open up the rest of my skin here just to give our exposure so we can get some pedicle length. Now you can see more readily the brachioradialis. So we'll just incise that fascia that exists between the brachioradialis and the flexor carpi radialis. And now you see the radial artery starting to emerge from that interval. I'm just going to keep on incising this. Usually we'll introduce some self-retaining retractors to give ourselves some better exposure. And here you can see better length on that radial artery. I'm not shy about taking a little bit of the fascia of the deep musculature that's investing the radial artery so that I can avoid injuring it or separating it. And again, you'll keep on just dissecting further and further as we go along in order to get more pedicle length on the flap itself, and we'll just continue to garner length. In this case, I'll separate it high up, and really you just take as much length as you need and it can get an extraordinarily long pedicle out of it. The big issue ends up being that as you go more proximally, there is a tendency for there to be a potential size mismatch if your donor vessels are not quite as big, because this is a direct branch from the brachial artery. Many times if I'm getting really proximal on this stuff, I'm just going to make sure that I'm not taking down my brachial artery and do one more clamp test prior to actually ligating this vessel to make sure that I haven't somehow missed an aberrant bifurcation or something like that. I'm just going to reset my retractor to allow further visualization, and we'll just incise the skin further to see if we can dissect all the way up to the origin. Just reintroduce the self-retaining retractor a little bit further to allow you to kind of see where that pedicle sits and how nice and big and long it is. And you can also continue that dissection. Now, should you have taken the cephalic vein, you'll oftentimes have the vein coming into the side of the vessel here, and it'll be in the subcutaneous tissue, and you'll need to do a subcutaneous dissection there. But in this case, you can nicely see radial artery flap. We have not taken it all the way to the bifurcation, but nice long pedicle, robust flap.